Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, a faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School here on the Duluth campus, and a family physician at the Gateway Family Health Clinic in Moose Lake. I am your host for our program tonight on neurologic problems, headaches, stroke, MS, and Alzheimer's disease. The success of this program is very dependent on you, the viewer. So please call in your questions tonight or send them to our email address, ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Vikram Jadhav, a neurologist with Essentia Health, Dr. Chris Thiessen, a family physician with Gateway Family Health in Moose Lake, and Dr. John Wood, a family medicine physician with the Duluth Family Medicine Residency Program. Our medical students answering the phones tonight are Jenna Carlson of Royalton, Minnesota, Lindsay Montag of Sauk Rapids, Minnesota, and Mackenzie Peterson of Laverne, Minnesota. And now on to tonight's program on neurologic problems, headaches, stroke, MS, and Alzheimer's disease. Just like to take a moment and let you gentlemen introduce yourself. Dr. Wood, can you tell us a little bit about yourself or your practice, what you're doing?
Thanks a lot, Dr. Christensen. Yeah, John Wood here. I'm one of the faculty at the Duluth Family Medicine Residency Program, which is, for those of you who don't know, after medical school, every medical student has to do a residency, which is anywhere from, say, 3 to 9 years in length, depending on your specialty. And for us, for family medicine, where we learn many different skills, primarily our mission is mainly to work in rural areas, underserved areas. And so I'm one of the faculty that helps train those beautiful young physicians to do that work. So I've been privileged to do it for about 10 years.
Dr. Thiessen?
I'm Christopher Thiessen. I work at Gateway Family Health Clinic in Moose Lake, and I do all sorts of medicine in a rural area, just like Dr. Wood trained us to do.
Dr. Jadhav?
Hi, thanks for having me on the program. So my name is Dr. Vik Jadhav, and I'm one of the stroke and interventional neurologists at Essentia St. Mary's Hospital here in Duluth. So primarily our specialty deals with problems of the head, of the blood vessels of the head, the neck, and the spine. So essentially you can call us like cerebral plumbers, because we make sure that we keep the pipes that are going into the head and the neck and the spine open.
Thank you very much, gentlemen, and welcome again. Dr. Wood, can you tell us what a stroke is or a CVA and give us some language?
Thanks a lot for asking, Dr. Christensen. So stroke, or CVA, meaning cerebrovascular accident, probably been around as long as people have been on the earth. And you can think of it as simply as the plumbing, as we just alluded to. The blood vessels are very tenuous. They work when they work great, but when they don't work, sometimes the outcomes can be catastrophic. And you can think of a stroke as hemorrhagic, where suddenly a blood vessel will burst and you'll get a lot of bleeding. And that might present differently than probably the more common kind of stroke is ischemic stroke, which is seen from a variety of conditions, say atrial fibrillation, hypertension, high blood pressure, diabetes, smoking. All these kind of diseases can lead to those states that can make one predisposed to stroke, whether hemorrhagic or ischemic. One thing I just want to say about stroke is it's really important to recognize the signs and symptoms of a stroke, and there's an acronym called BFAST, which I think maybe many people in this audience are aware of, but B would stand for balance, E would stand for eyes, F would stand for face, A would stand for arms if your arms are not working properly, S would stand for speech, and T would stand for time. And I think the important thing about a stroke is to recognize if your partner or yourself are acting a little funny. It can be anything, it can be subtle, or it can be, again, hard to miss. But time is a very important factor, and we'll be talking about things that you can do in a stroke, but it's really important to get to a medical facility as quickly as possible. I hope that was helpful.
Well, that's very good, thank you. Thanks for bringing in the Be Fast piece.
In fact, that has been expanded to be faster.
Oh.
So when you have signs that are representing the acronym Be Fast, then you go to the nearest ER. So that's the Be Faster.
Like in Moose
So
Lake.
call 911 or go to the nearest ER, because as you alluded to, time is of the essence, and you have to get certain treatments within time. And if the patients who are having stroke symptoms, stroke signs, if they get that treatment within a certain time window, then they are likely to have a very good outcome.
So time is brain.
Time is brain, totally.
As long as you're on the verge of this, then what happens when they come into your shop, and what do you do?
Patients who have symptoms of stroke. So one thing I would also like to point out, there is a lot of awareness of in the cardiology world, when somebody has a heart attack or they feel that they're having a heart attack, they have a chest pain or some tingling in the arm, and patients would immediately go in. But with stroke, sometimes patients tend to delay going into the nearest ER because they just feel that, oh, it might just be a little bit of a tingling or a slept on the wrong side. So the acronym that Dr. Wood alluded to, if patients recognize that, come into the ER. If they get to the ER within the first 4.5 hours from the symptom onset, you are eligible to get a clot busting medication, and this medication can go and break up the clot, which is blocking the blood vessel that is preventing the blood from flowing to that part of the brain and preventing oxygenation of the brain. So the medication can lyse the clot or break open the clot. Sometimes the medication may not work to open up the clot, and that's where our specialty comes in, wherein we put in a catheter either through the arm or through the leg blood vessel and go all the way up to the neck and then into the brain, and we put in a device to capture the clot and pull it out, thereby restoring blood flow to that part of the brain and providing oxygen and blood flowing back to the brain. And then that way you are able to stop the stroke from progressing, salvage important viable parts of the brain, and improve recovery function in the patient.
So Dr. Thiessen, you're the ER doc today. I've been away from that for a while. Tell me about the presentation in the emergency room and what kind of presentations you see. Let's just stay with stroke for a bit.
Sure.
In my mind, I always remember the ones that happened at night. It seems like they were the hardest ones, but what do you think?
So I've certainly seen a lot, and that can range from someone who just feels like their face is suddenly drooping, to someone who can't move their right side and can't speak. And I think for many of those, people often notice that because the patient themselves may have less of an idea what is happening, that something is different. And it depends on the stroke, but sometimes it takes a loved one to look at somebody and say, you know, this is really different, because the patient may not really know that something is gone. There's a phenomenon called neglect, where that part of the brain that's missing is just not, the patient isn't aware of it.
I changed our sequence a little bit. We were going to talk about headaches too.
Mm-hmm.
I'm going to bring you back to that.
Sure.
Because stroke can be a headache also. And
Yes.
why don't you give us just a bit of a primer on the headaches?
There are many different types of headaches, and we see a few of them in particular in primary care. One is migraine headache, and I think many people think of migraines as just the very severe headaches. But a migraine will tend to have some things like being maybe on one side of the head, feeling throbbing, maybe giving you nausea, and then also sensitivity to light or sound or social interaction. So a lot of people with migraine may just sort of withdraw from being with other people and go take a nap and sleep. A lot of times migraines can be treated with things like ibuprofen or acetaminophen, but sometimes they need specialized medications, and we're happy to help out with that. Tension headaches we see a lot of too, and those tend to be maybe in the front or the back of the head, and maybe not as throbbing and more persistent. And I think a lot of people can tell when they're under stress or they may be having a reason for a tension headache. And one more I'd like to mention that we see fairly often is just medication overuse headache. I've had people who have a shoulder injury, and then after a week or two of using ibuprofen or something for that pain, they might develop a headache that's almost a withdrawal headache every day. And that's from taking that pain medication just for a couple weeks, bringing on the next headache, and having to take the medication to take it again to get rid of the headache. And that's something where we can also help with weaning off the medication and getting rid of those.
Thank you, very good. John, the worst headache that you could have.
Well, that
And then
would
let's bleed that, lead it over this way.
Yeah, it'd be kind of a thunderclap headache. The worst. That's always something. When I used to work in the ER too, that would be a question we'd ask, and if we got the answer that someone said yes, that would immediately make us think about certain kinds of bleeds, subarachnoid hemorrhage or whatever, and then we'd be referring ourselves to our colleagues to my left to send people down to Essentia Health or St. Luke's or one of our regional hospitals in order to get the interventions they need for those kinds of headaches. So not all headaches, some headaches can present as a stroke, some strokes can present as a headache. It's very complicated and it's often hard to figure out. I think the common theme here is we're talking about trying to get people into medical care as quickly as possible. And certainly if anybody's listening and they're having the worst headache of their life, and that's subjective, there's no answers to that. My headache might be different than your headache, but it's the worst headache of your life. You need to seek medical attention immediately.
Vic, do you want to carry on that one?
Sure, as Dr. Wood alluded to, the thunderclap headache is pretty much like the worst headache of your life presentation, and accompanied with the headache there'll be nausea, vomiting, and many a times, depending on how large the bleed is, then the patients might even be obtunded, like they can actually lose consciousness, or they might just have symptoms or signs that are mimicking, like basically it's a bleeding stroke. So you can be either paralyzed or not being able to breathe, and then the paramedics would have to come in and intubate so that you are able to breathe and put you on a mechanical ventilation. So these kind of headaches, they occur because of an aneurysm that has ruptured. So what essentially an aneurysm is, it's an outpouching or a weakness in the blood vessel wall, and it has reached an extent that the weakness is so much that the blood vessel has ruptured through that aneurysm, and the blood has gone between the layers of the brain. So there is blood inside the brain, and that's why the pressure inside the brain has spiked up, and this leads to further problems down the road. And unless it is treated, like the pressure inside the skull is treated, and also the aneurysm is secured by either coiling or putting stents with coils to block the flow of blood into that part of the brain where there is leakage or the blood has, or the vessel is bleeding, it could further lead to more problems. So aneurysm treatment is an important part and parcel of interventional neurology specialty.
Thank you. John, how do you diagnose a TIA, and what are the treatment options for that?
Well, I think what we're talking about is TIA would be a temporary or ischemic attack. You know, attack that the ischemia is what we talked about earlier, was the stroke-like symptoms, which, as Dr. Thiessen or Chris alluded to, can be variable: speech loss, paralyzed, loss of function on one side. The difference with a TIA is that those symptoms will resolve, usually within 24 hours. The problem with making a diagnosis of a TIA, it's retrospective, because often at the time you don't know that you're dealing with a TIA until the symptoms have passed and you can get complete resolution. I think of a TIA, as we were talking about heart attacks, as sort of an anginal symptoms. Your body is telling you something, that there's something wrong. Excuse me, I'm not looking at the camera. I apologize for that. I'm looking at my colleagues. So your body is telling you there's something wrong. And so this is a sign that you need to, one, get to the emergency room, get evaluated. You're going to have the same amount of testing that you would have for a stroke, but the issue is that these symptoms are going to resolve. The thing about a TIA is that once the TIA is passed, it's about managing risk factors. It's about managing the things that cause that: your high blood pressure, your smoking, your diabetes, these factors that have led to the ischemic part of the lack of oxygen and blood flow that's caused those symptoms in the first place.
Chris, I know that you've kind of covered this already, but just to brush it up a little bit, when should you go see the doctor for headaches, and then some options for headaches? And you've kind of covered some of this already.
There are a few specific things that might make it worse. I guess a lot of times headaches will have patterns, and so if you've had tension headaches and you know what they are and they're stable, that's not something that we worry about. But something that comes on rather quickly, like a thunderclap headache, is of course bad. Headaches that come on for the first time after age 50, headaches with fever or some other illness. If you have cancer and there are new headaches, we might think that there's some other problem that's causing the headache. headaches with other nerve symptoms. So if your hand isn't working, like in the concern of a stroke, that would also tell you to go in and get that checked out. Those are the ones that I can think of right now.
So, John, let's go on to post-concussion.
Sure. So sometimes after a concussion, you can have debilitating headaches, and the problem or the challenges with post-concussive headaches and concussions in general is that treatment is we're lacking a common consensus and I think definitive treatment for that at this point in time. I think we've gotten a lot better at recognizing that the brain is a very fragile vessel, like injuries that maybe the four of us would have thought as a child would have been relatively minor are now treated probably a little bit differently, meaning that the kind of injuries that we might have had in sports would be treated much differently now. But post-concussive headaches can be very challenging because your brain is trying to sort of normalize its function, and there's the only real treatment for that is obviously medications to help with the headaches, but time and then recognition that this is an issue. So if anyone has had a concussion or a head injury, which can be really, frankly, relatively minor, it's important to speak with your family physician or your physician, who will often be able to get referred to a neurologist for some post-concussive care.
So Vic, I'm circling back to you now. We've had somebody that's had a significant concussion, and then let's go into subdural, epidural, those kind of areas. And does that fit into your specialty a bit also?
Yes, it does, and I'm glad you brought that topic up because this is a new and exciting developing field wherein we can use the same catheter-based technology to take care of patients who have suffered because of a bleed from the concussion. So there are a couple of different kinds of bleeds which are probably not as common as, say, intracerebral hemorrhage, like there is bleeding inside the brain, but there is bleeding between the layers of the brain, between the brain and the skull. So one of the common ones that we do see is subdural hemorrhage, and this unfortunately is seen in patients at an advanced age. So for these kind of bleeds, the blood keeps on gradually accumulating and expanding, and that can cause some mass effects. So the brain can get kind of squished over time, and this can lead to gradual development of, say, deficits on the other side of the body, whereas there could be weakness, or patients can start losing their language function, or they can start becoming imbalanced, and gait could be a problem. So for these patients, if they are able to tolerate surgery, then the neurosurgeons can go in and just put in like a small hole in the skull and drain that blood out, or sometimes they can take a part of the skull out and then drain the blood out. But many a times the patients are older and they are not able to tolerate surgeries. So for these patients, we put in again a catheter through the groin or the arm, go all the way up to the neck, and then outside the brain this time, these are very small blood vessels that feed all the way over the scalp, and then they dip inside into the membranes that supply where the blood has accumulated. And by embolizing or blocking these small distal blood vessels, we can treat and prevent future accumulation of blood. And so that way the patients will have a much improved chances of recovery, faster recovery, and they can even go back sometimes on the medications that cause this bleeding in the first time. Sometimes they are on aspirin, Plavix, or some blood thinners which contribute to bleeding of these types.
That is a change to what I grew up with.
Definitely it's a change.
Yeah. It is. It's very good. And yes, this type of care is available here in Duluth.
It is.
Is there an increased risk of future strokes if a patient has visual loss and difficulty speaking just prior to getting a migraine headache? So we'll walk into the swamp a little on that. What do you think, Chris?
So migraines seem to have a lot to do with the blood vessels in the brain, and that may be part of the feeling of throbbing in the head. And sometimes the signaling that brings on a migraine can also squeeze down the blood vessels so much that you can have a stroke from a migraine. And fortunately, I haven't seen many people with that, but it is enough of a problem to make it, I think, sometimes very difficult to understand whether we're dealing with headache or stroke or something else like MS.
And it's very difficult to figure it out.
It can be.
In the end, yes. You have anything to add on that one?
Thankfully, there are a lot of investigations that can be done even before the patient can be seen by a neurologist, and this would be doing an MRI of the brain or a CT scan of the brain initially. So sometimes these pathologies or the diseases that are contributing to the headaches or the vision problems, they can be teased out before a specialist even can see the patient.
Very good. John, how does trigeminal neuralgia fit in with strokes?
Boy.
And personally, I'm not aware that it does.
I frankly am searching my brain, and I'm not aware that there's any causality between trigeminal neuralgia and stroke. I would say trigeminal neuralgia is a challenging diagnosis, and neurologically that's a tough thing to treat, but I don't think that it's related to stroke.
It's a different problem.
Yeah.
Wasn't there also an uptick in trigeminal neuralgia during COVID?
Yes.
Okay. I thought there was a connection where
Yeah,
there
well,
had been a few more of
And,
those
and we don't know a whole lot about COVID, I don't think even yet, but yes.
Yeah. Okay. And trigeminal neuralgia is a horrible thing, and sometimes misdiagnosed as dental problems for a few people. So if you have some sort of problem with horrible pain that's worse with tapping, see a doctor and try and get it taken care of. It's awful.
Yeah.
As long as you're in that area, can TMJ problems cause headaches?
Oh, yes. So the joint, right, where your jaw works is something that can get arthritis just like any other joint and cause pain. And that's another spot that can be really awful, especially when people have to talk or, of course, you have to chew to eat. Those things can make it worse, and those are everyday things that we have to do.
John, can baby aspirin, are the daily benefits for, does baby aspirin have daily benefits for preventing stroke, or is it hogwash?
It depends on when you answer that question. Answering it in 2024 is a little different than 2014 or 2010 or whatever. So folks that have had identified risk factors for heart disease, stroke, who have had a stroke, who have had an MI, or candidates for a daily aspirin. But we don't universally recommend, say, the average person walking down the street to take a daily aspirin like we used to. You know what I mean? But conceptually, though, the baby aspirin can help thin your blood out, makes the platelets a little less sticky, helps the blood flow a little better. So yes.
Chris, can diet and exercise help prevent Alzheimer's disease?
Absolutely. Regular exercise is one of the better ways to keep yourself from getting Alzheimer's. And diet, certainly avoiding alcohol and trying to eat healthy with reduced fats to lower the risk of damage to your blood vessels. I'll also add avoiding smoking.
You guys haven't talked much about alcohol as we deal with stroke and other problems. Is alcohol a significant factor in stroke and neurologic disease? And any one of you can jump in on that.
I've seen a lot of alcohol-related neurologic disease, a lot of it due to withdrawal from alcohol or overuse causing dementia. And with stroke, I don't know about the connection.
Yes, definitely there is. I would just tell the patients, if somebody's asking me a question about that, a little moderation alcohol is okay, because sometimes red wine, it does have antioxidant properties, and that might be beneficial, but I always tell has to be in moderation. And when I tell them it's one glass, you define the size of the glass to the patient first and make sure it's not a big one. So tell them alcohol such as in red wine would definitely be helpful sometimes, but all other forms of alcohol, if not done in moderation, is not good for stroke, and it is likely to be deleterious and harmful for stroke patients.
John, are blue light glasses really effective in preventing headaches?
I'll have to say I have absolutely no idea. I'm just going to take the fifth on that one. Maybe my colleagues to my left have heard. I honestly don't know.
I haven't heard anything about that.
No, neither.
Same, right straight, okay. Is there something as a pinprick headache above the right eyebrow? This person apparently has a pinprick headache above the right eyebrow. What would cause that? We have about a minute.
There's a nerve right in the middle of the eyebrow that can be irritated, and perhaps it's that.
Maybe the supraorbital, yeah,
Yeah.
or it comes out of the foramen, maybe
Yeah.
that's it, or migraine.
I've had a couple people
Yeah.
with that.
And you've got stroke thrombectomy available here in Duluth.
Yes, we have that. We established the program way back in 2018, so this would be the 6th year, and it has been very successful because now the treatment is available in the backyard, in so to say, in Northland, because patients do not have to be transferred to the cities for stroke thrombectomy treatment. That is the stent retriever, the catheter treatment that I mentioned about, because with every passing minute, patients are losing brain cells. So for 1 minute of prevention of blood flow, patients are losing about 2 million brain cells. So you can calculate and keep on adding the amount of time. So if by getting this treatment in Duluth itself, we are able to salvage the brain for the stroke patients.
Great discussion tonight, gentlemen. Really, really good. We learned a lot of new things. I want to thank our panelists, Dr. Vikram Jadhav, Dr. Chris Thiessen, and Dr. John Wood, and our medical student volunteers, Jenna Carlson, Lindsay Montag, and Mackenzie Peterson. Please join Mary Morehouse next week for a mental health program on stress and anxiety. Thank you for watching and have a great night.